Hi, everyone. Thanks, KP. I did start the last talk I gave with BCNA with the same story as to why I don't really like being called Dr. White, because, when I finished my medical training and I put my little white coat on, I went and saw my first patient as an eager young resident, and I said, "My name is Dr. White." And the woman looked at me very dryly and said, "In the UK, Dr. Whites are a sanitary pad." I think she put me in my place pretty quickly. And since then, I'm Michelle White. So, firstly, I'd like to thank Kirsten and BCNA for asking me to be involved in this really exciting event. This is your day, so I'm hoping I'm giving the information you want to hear, but if you disagree with something or you want to ask a question, please just whack your hand up. It's very casual. I really don't want you to feel like you've got to wait to the end to ask anything, because if you're like me, at the end of a talk, you've forgotten what the question was. So ask away as you feel the need. My topic today is discussing the current and emerging treatments to support living well with early stage breast cancer. So in Australia in 2023, breast cancer is unfortunately quite a common illness, affecting 1 in 7 women. And while it's much less common in men, we do see men diagnosed with breast cancer. And indeed, many men think they can't get breast cancer, so it's quite a shock to them. And we're really trying to make sure we provide support for them as well as to the many women diagnosed. It's really important, I think, to remember that the vast majority of women and men diagnosed with early stage breast cancer will be cured of their illness. However, not everyone. And so ongoing research is absolutely aimed at improving those statistics. So a very quick biology lesson for those who would like one. Just as a reminder, the breast is essentially a structure, with the breast tissue, with the nipple in the centre. We don't have a pointer, do we? Doesn't matter, too high tech. And essentially the lobes make up the area where the milk is made, as you can see in the image, leading to the ducts, and then the milk can come out of the nipple. And so essentially breast cancer can develop in both the lobules and also the ducts of the breast. Many people get a bit confused about the differences between DCIS and invasive breast cancer. So they are both cancers affecting the breast. However, the DCIS means that the cancer is very localised, actually to just within the ducts of the breast. So when that diagnosis is made, it still needs treatment. Often it's surgery and radiation treatment, sometimes a mastectomy, but this is not life-threatening. If it's left alone, it can become an invasive cancer and become life-threatening, but on its own, it is not potentially life-threatening at that time. The little cartoon on the right is showing us the evolution of a normal duct to a duct with what's called DCIS, where there's some abnormal cells growing within the lumen of the duct. And then finally, invasive cancer, where the cancer cells have worked out how to spread to other parts of the body. And that's where we're dealing, with a potentially life-threatening illness. The term breast cancer is a really broad term these days, and there's lots and lots of little subtypes of breast cancer. Some patients want to know an awful lot of information about the subtype of breast cancer that they've got, and other people are pretty happy to just know my diagnosis was breast cancer. But by far and away, the most common is one that develops from the ducts, and the poor thing only gets a name now called no special type, which is a bit demoralising, but that's all it gets. It is by far and away the most common. The next most common is what's called invasive lobular cancer, and that's responsible for about 20% of all breast cancers. And then there's a lot of rarer, but certainly important diagnoses like inflammatory breast cancer, and a very, very long list of diagnoses. And the behaviour of some of these illnesses is very, very different, and that's why it is important for the doctors to know what subtype the patient has. So let's talk about risk factors for breast cancer. We've got an illness that affects 1 in 7 women in Australia. What would be the risk factors that we need to look at? Now, this is a bit of a complicated table, but essentially the list on the left is features that would be associated with a low risk, and the features on the right are in the middle are the high risk, And the last column is the relative risk. So how much that increases your risk of those things happening. So in this case, we're looking at the factors on the left. What impact could they have on your risk of developing breast cancer? By far and away, the most important risk factor is carrying a genetic predisposition that increases your risk of developing breast cancer. So that certainly increases a woman and a man's risk very substantially. And if I'm honest, most of the other risk factors are all smaller risk factors. And I will often see a woman who comes in saying, Michelle, you know, why has this happened to me? I had 7 children. I breastfed them, you know, all for more than 12 months. You know, I did all the right things. And here I am sitting with breast cancer. And that's absolutely true, because all of these risk factors, they're just minor differences in your risk. We do worry about, for example, women who have very heavy alcohol intake. That is a significant risk factor, and some of the other factors that are there. But at the end of the day, for the majority of people diagnosed, you can't really put your finger on why it has happened. I usually say to the women, it's because you're female, and for most women, it's because you're over 50. And that's really their main risk factors. So, you know, it can be a multitude of small factors all contributing. You know, what age did you have your babies? Did you breastfeed your babies? How much alcohol you drink? The image down the bottom, what genes were you born with? Have you had radiation to your chest? That's definitely a significant risk factor. And carrying a bit of weight. What I really wanted to point out as well is the things that are not risk factors for breast cancer, because I do a session called Living Well with Metastatic Disease, and my topic is myths. And so the first question I always ask everyone is, okay, well, what's the flavour of the month this month? What are you being told by your friends and family or well-meaning people will fix your cancer? And, you know, sometimes it's high-dose asparagus, sometimes it's activated almonds. You know, there's a whole list of things which, you know, as clinicians, if we had good evidence to support, we would recommend, but we don't have that evidence. But certainly aluminium-based deodorants, wearing an underwire bra, eating, you know, dairy or meat or chicken that might have hormones in it, they're all the, you know, none of these are significant risk factors. And as we say to everyone, a healthy, balanced diet. And the worst thing I think a woman can do, or man, when they're diagnosed, is radically change their diet. And I've had patients come in and they've turned orange because they're juicing so many carrots that honestly they're drinking a bag of carrots a day, and they look like that funny, well, Donald Trumpish in their appearance, which is a hard look to carry off.
Sorry, we are ready for that room. So the metastatic patient, sorry to interrupt.
Oh, good. No, that's fine. Good to go? Okay. We know that breast cancer can be diagnosed a few different ways. Obviously, many women are diagnosed through breast screen, which is a fantastic service. Now, someone can tell me, what's the service like up here? Is it hard to get into breast screen, or where do you have to go? Do they have a van? And how often does it come? Once a year. Okay. And does that... Hey? Right, okay. Some women are diagnosed with breast cancer by feeling the lump themselves, and sometimes a doctor picks it up on a routine examination. In Australia, breast screen is available, we're pretty lucky that way, to all women over the age of 50, and they're entitled to 2 yearly breast screen. For women who are over 40 and have a family history, they can also apply to breast screen. But there's really new exciting modalities coming through. I think we've all seen that cartoon about how a man must have developed the mammogram, because if we had to do the same test to their bits, I think they would have come up with a better test a long time ago. But you know, there are much more sensitive new modalities coming through, and by that I mean MRI scans, which are certainly recommended for younger women who are at high risk of breast cancer. They give really intricate detail. And the other thing that's coming through and hopefully will be incorporated into breast screen is what's called contrast mammogram, where essentially they inject like a CT contrast and then quickly do the mammogram. And the images, again, it's very, very sensitive and picking up a lot of stuff that would have been missed otherwise. MRI scans are very sensitive. In fact, in some patients, they're too sensitive and they pick up things that don't turn out to be anything at all. So they can generate anxiety in that setting. Does anyone know how they do an MRI of breasts? So essentially what they do is there's a table with 2 holes and you put your breasts in the holes. So you can see that woman's breasts look quite long. It's because they're hanging downwards. But it means that they get really good information of the breast tissue and can pick up a lot more information than a standard mammogram and ultrasound can. To make a diagnosis of cancer, we have to have a biopsy. And while they can be unpleasant tests and some people can get a lot of bruising associated with them, they're really important for us to work out, is this definitely cancer? Because sometimes the scans get it wrong. And if it is cancer, what subtype of cancer is it? Because the sort of information we want to know is, remember I said before there was the NST, the no special type cancers versus lobular cancers. Also, how quick is it growing? What's called the grade of the cancer. And finally, what's driving the growth of the cancer? And this is when we start talking about receptors, estrogen receptor, progesterone receptors being the main female hormones that can drive cancer growth, but also looking at the HER2, which is another pathway I'll discuss in a minute. And finally, those cancers that aren't driven by any of those factors, what's known as the triple-negative breast cancer. And the reason it's really important to clarify what subtype it is that the treatments and prognosis can be affected by that information. So you can see, just going down on the left side, luminal means a hormone-driven breast cancer. So luminal A is the most hormone-driven, luminal B a bit less hormone-driven. Then we talked already about the HER2 and finally the triple negative. And what we know is that the treatments will be dictated by what subtype of breast cancer a patient has. Once we've diagnosed that it is breast cancer and we know what subtype it is, usually a woman would undergo first having surgery with either a lumpectomy or a mastectomy and getting some idea what's happening to the first place that breast cancer likes to spread to, which is the local lymph nodes, either with what's called a sentinel lymph node biopsy, or if we already know there's some lymph node involvement, they take out more lymph glands and that's known as an axillary clearance. However, there's been a real change in the way we order our cancer treatments over recent years. And for some subtypes of breast cancer, we actually give the chemotherapy and some targeted treatment or even immunotherapy before the patient comes to have their operation. And this is particularly relevant for 2 subtypes of breast cancer, the triple negative subtype and the HER2 positive subtype. And I'll discuss why we do that in a bit more detail. So when we're talking about the sentinel lymph node biopsy, this is the procedure that's involved. Essentially what this test is trying to do is identify which are the main couple of lymph nodes or one lymph node that cancer would first spread to. Because if that's clear, the chance that other lymph glands are clear is really small. And the reason that this technique was developed is that when you take out lots of lymph nodes from under the arm, we know that the woman or man has a significant risk of lymphedema, which is a really debilitating long-term health concern, where women can have swelling of the arms, discomfort in the arms, heaviness in the arms. And so we're trying always our best to minimise the risk of that happening. So what happens is essentially, and most women who've had this done say it's not the most pleasant of procedure, it's quite painful, but really it's been a very helpful thing to work out where to get the lymph gland from. So they inject something that's radioactive and also a blue dye. And then when the surgeon is doing the operation, he looks, when he opens up under the arm, he looks where the blue lymph glands are and just takes out those that have turned blue, meaning that's where the cancer spread to. So it's a very clever technique because really what we're trying to do is remove fewer and fewer lymph nodes from that armpit. Staging of breast cancer is one of those things that is very important from a clinical perspective because it may determine what treatments we offer, the risk of the cancer returning, but also really important for the patient to be aware of. As a general rule, stage 1 is small cancers that haven't spread to lymph nodes. Stage 2 is bigger tumours that potentially have involvement of the lymph nodes. Stage 3 is bigger cancers and more lymph nodes under the arm, and stage 4 is when it's spread beyond the breast and the lymph nodes. So we've mentioned already the types of surgery that we might consider, a lumpectomy or a mastectomy. We've already talked briefly about chemo and immunotherapy and targeted treatments. And other treatments that women and men diagnosed with breast cancer might be exposed to is hormonal therapy and radiation. In the olden days, it used to essentially just be up to the treating doctor to say, right, I reckon you should do this. And we now know that that's really not a very good way to manage patients. And we now love the model that we are able to achieve in breast cancer where we have multidisciplinary meetings. So in these meetings, we will have medical oncologists, radiation oncologists, the surgeons, the pathologists, the breast care nurses, often members of the allied health team and psychologists. And we discuss each case and formulate a consensus view about what's the best treatment for that patient. And so a lot of patients get great comfort from that. Patients often ask me, why can't I come to the meeting? I think often the language is quite complicated and we're always very happy to, I see my job is to translate the recommendations of the MDT to my patient. And I think also an advantage, because I know my patients, I can present if they've got a particular perspective about how aggressive they want this illness treated, because some patients do have opinions. And often the GP is certainly, if we can, get involved, because again, they often know the patient best. So they're a really great initiative. I suspect most of them are probably done via Zoom for rural communities, but I'm not sure if anyone... Oh, yeah. Hi. Yep. Wow, fantastic. Okay, well we used to be mostly face-to-face, but a number of places have... We've got... Yeah. But, they're a huge asset. When we're making decisions about what treatments a patient should have, we're really basing it on historical trials of other patients who had similar cancers and what was seen in clinical trials to work well. However, there's a much greater focus these days on trying to personalise the treatment to that particular patient and that particular cancer. And these new tests that are coming through really have relevance for early stage breast cancer and advanced breast cancer. And, I think in 5 or 10 years will absolutely be the standard of care around the world. What these tests really involve is, in the case of a woman who's got a hormone-positive breast cancer where we're not sure if we should give her chemo as well, we're able to get some of the tumour assessed in a particular laboratory, and they're able to tell us if this cancer is a much more aggressive one and would benefit from chemotherapy, or actually a really good prognosis one and all the patient needs is the hormone blockers. There are 3 tests available to us in Australia. The Oncotype is the one that there's the most data about, but that's in the US. It takes bloody 4 weeks to get a result, and it's unbelievably expensive. It's about 6,000 Australian dollars, completely out of pocket. No money back from Medicare, health funds, anybody. And that's really beyond the reach for the vast majority of Australians. So we have a couple of local tests, but again, they're very, very expensive. The Prosigna's done in Brisbane, and EndoPredict is one done in Melbourne. They're about $3,000, but again, that's a lot of money. And we think that's very good money for value for money for the government, but despite BCNA, lots of advocacy groups and the companies that run these tests applying to the government, unfortunately, they've not been completely successful to date in getting them fully funded. But hopefully this will have to be something that's addressed in time, because you can imagine that for the federal government, saving someone doing 3 months of chemo with their time off work, the impacts on the patient and their family, it clearly would be cost-effective in the long term, but we're not there yet. And so it comes down to this very horrible issue of equity, where you can't have, I don't think in Australia, a situation where if you're rich, you can get different levels of care for your breast cancer than if you're struggling financially. And certainly in the current environment, for many, many patients, this is not something that's routinely done. It's certainly not routinely done. But I'm really hopeful because in many centres around the world, in Europe and in the US, it's commonly done. So looking at surgery, for the vast majority of women diagnosed with early stage breast cancer, a lumpectomy should take place. Really, mastectomy is typically restricted for women who have bigger tumours, if they've got lots of tumours in the same breast, if the patient elects to have a mastectomy, if they carry BRCA or one of the other risk genes. Male patients, we always do a complete mastectomy, remove all their breast tissue, or if a patient can't have radiation for a variety of reasons. A mastectomy, obviously many patients still undergo a mastectomy in 2023, and it certainly should be standard of care that they are all offered reconstruction in 2023. Now, I know that there have been issues with access to plastic surgery, particularly in rural settings, and this is, again, when we come back to our equity concerns, we want patients in the city to not be able to have opportunities that patients in the country have. So I think, again, BCNA are working very hard in advocacy capacity to try and improve this situation. And I will say, more and more women these days say to me, Michelle, I don't want a reconstruction. You know what? I'm happy to be flat-chested. And often they then request the other breast be removed for symmetry. So, there's no judgment from a medical perspective. It's more about a patient having the opportunity to have a recon if that's what they'd like to do, or go flat if they don't want to. The surgeons try very hard these days to use the patient's own tissue because cosmetically it's often a better outcome, and there's obviously been some concerns in the past about implants, but they're very clever. They can take tummies and they can take thighs and they can take bits of your back to make new breasts. So they really are artists these days. The term oncoplastic surgery is talking about when you're having your lumpectomy. In the olden days, if you were having a biggish lump removed but you didn't want a mastectomy, when you had your lumpectomy, you were pretty much left with a divot in your breast, a decent hole, which didn't worry everyone, but is certainly quite disfiguring. And if it's certainly in the medial part of your breast and you wanted to wear a bra, it could have implications from that perspective. So now the surgeons try very hard to do this additional clever surgery where they move the tissue around to try and give women the best outcome. So let's talk about treatments. Chemotherapy is obviously a treatment that is commonly used for early stage breast cancer. I like to think of it as like ingredients in a recipe. There are certain combinations that work well together that have been shown in clinical trials to be, better than previous treatments in reducing risk. So combinations like AC, some people, I know I've got patients who on the internet have read about the red devil. One of the drugs looks like red cordial, and when you pass urine for the first few days, you pass red wee. So it's often called the red devil. Taxotere, they're all commonly used drugs that, as oncologists, I don't know why they like to give them big names. I think it's so that we think we're smarter than we are, but they're commonly used. And we know the common side effects of treatment, the acute side effects. Most people cope pretty well with the acute side effects. They know it's going to be for 3 or 6 months. They can cope. Hair loss is clearly devastating, but many centres are now having access to scalp cooling. Is that something? No, nothing up, not at all, no. Yep. So again, let's get back to that equity issue that, we can't have situations where treatments are offered in some areas and the other. It's not perfect, but, for some patients it's a really effective treatment in keeping their hair. We know nausea and vomiting used to be a huge problem with chemotherapy, and now we have really, really good drugs to help manage that. I do tell the story that when my kids were little and I was walking along the street and I saw an ex-patient from a few years ago, and she took one look at me and she vomited because in her head I represented the whole cancer journey. We hadn't seen each other for a number of years, but that was how powerful that guttural reaction was to her previous treatment. And thankfully, the drugs we have to manage nausea and vomiting these days are so much better than they were back then. We know tiredness is a huge problem with our treatment and also suppression of immune system, but we've got injections to help with that. So this is an image of patients having scalp cooling. So essentially it's like wearing like a tight swimming cap with a tube that's attached to I call it the very expensive air conditioner. And once the nursing staff turn it on, it drops the temperature. So patients do get like that ice cream headache feeling. It's not that pleasant when it first goes on, but once it reaches its steady state, but you have to keep it on before the treatment for about half an hour, the whole chemo time, and about 45 minutes afterwards. So it makes your day very long. And it's not for everyone. Not everyone can tolerate that degree of cold. Long-term complications of the treatment, these are the ones that increasingly as oncologists we're really concerned about. So what we want obviously is a cured patient from her breast cancer, but we do not want to be leaving her with permanent disability from her treatment. And the sort of issues that we see long-term in our patients, most commonly the one that's really debilitating for some patients is what's called peripheral neuropathy, where the chemotherapy affects the nerve endings in hands and feet, and that can certainly be very debilitating, cause pain and impact function. And so it's really important that we manage the chemotherapy to try and prevent that developing. Some of the chemo drugs can affect the heart's function. We know our drugs can affect fertility, which is certainly relevant for our young patients, male and female. And a young patient going through menopause in their 30s and 40s can really have a very negative impact on their quality of life. Leukemia is a side effect, but thankfully it's really rare. Hormone treatments, as I've already said, the majority of breast cancers are hormone-driven, so 70% of patients will have an ER-positive cancer or hormone-positive breast cancer and will be recommended to have hormone blockers. And the big difference patients tell me all the time is, Michelle, I could cope with my chemo because it was 3 or 6 months and I had that in my head, I could do it. But you're talking about 5 years or 7 years or 10 years of feeling this way, and I find it pretty tough. So I think we really do need to improve our management of many of the side effects we see with these treatments. So there's a whole variety of different hormone blockers that can be used. Tamoxifen, what's called aromatase inhibitors, which are the commonly used drugs for postmenopausal women, taking out ovaries or tricking your body into being postmenopausal for a young woman. And for men, they also can have hormone-positive breast cancer. And drugs like tamoxifen or, again, aromatase inhibitors, but they need to have an injection with that. And I haven't got many male breast cancer patients, but certainly their wives always tell me that, it's the ultimate revenge that their husbands actually get to see what a hot flush feels like after listening to their wife complain about them often for many, many years. These are some of the symptoms of a natural menopause, okay? So I like to think of menopause associated with our hormone blockers as menopause on speed, right? So these are the standard ones, and then we ramp them up with our further blockade of estrogen. But you can see that every single part of a woman's body can be affected by menopause. Some of them physical, some of them psychological, and I do think the psychological ones are often particularly ignored in the general community, but I think there is getting a greater voice addressing some of these. And the common side effects we see with our hormone blockers are hot flushes, changes in vaginal secretions, muscle cramps, weight gain. Certainly about half the women put on tamoxifen do put on weight, which, as many women will say, if they've lost their hair with chemotherapy and then they put on the weight, they say, I look in the mirror and I don't know who she is. So from a self-esteem perspective, these are really important things to address. There are rare complications of tamoxifen, cancer of the uterus and deep vein thrombosis or DVT, but they're really quite rare. And the aromatase inhibitors, the biggest challenge we see are the stiff joints. So women often say, I feel like I've aged 20 years. When I get out of a chair, I walk like a nana. Once I get going, I'm all right, but it's just that initiation of movement. The vaginal dryness with this treatment can be very profound. And again, I think the medical fraternity are not very good at addressing this. We often don't discuss it unless the patient brings it up. But when you do bring it up, I'm often shocked how frequently patients are really debilitated by it. And osteoporosis can be a complication of the treatment. What we now know is there are actually really good treatments for some of these side effects. I'm not saying everyone on these treatments has a perfect quality of life, but often we can see a huge difference in symptoms by being really aggressive with our management. So for hot flushes, we've got a whole swag of drugs that their primary function is not to treat hot flushes, but they either are for depression or for bladder irritability or for nerve pain. And they've all just been found incidentally to help hot flushes. So I really encourage patients to discuss that with their treating oncologist. Vaginal dryness is a bit of a controversial topic in that topical estrogen can be used to improve the symptoms. Some oncologists are not comfortable with it. Many of us feel the amount that leaks into the bloodstream is very small and are comfortable using it. But again, it would need to be a discussion between the patient and their treating oncologist. Sore joints, it's all about exercise really is the key to try and keep the joints as supple as possible. Lowered mood, I think, does need to be addressed. And I think it's often the family that say, hey, I've noticed that you're either more cranky, which, is a common menopausal symptom, or that, you just seem flat, you're not getting your normal joy in life. So I think it's important patients do listen to their families because they do know them best. And I think it's really important, to take that list to your oncologist that, truthfully represents how you're going. I'll often see a patient who'll have their partner sitting beside them, and I'll say, how's it going? And they'll go, oh yeah, great, no issues whatsoever. And the partner looks at them like they're going to, attack them and say, what are you talking about? You struggle out of bed, you're having 20 hot flushes a day, and, and sex is very painful and it's really affecting our relationship. I think it's really important to have that trust with your treating team that you can discuss these issues, even though sometimes it can feel a bit awkward at the start. I quickly wanted to look at advances in radiation. The techniques are getting better. We're trying to minimise the damage to underlying structures like hearts and lungs. And patients with a lumpectomy will nearly always be recommended a radiation, and patients who have a mastectomy, if they've got higher risk disease, they also will be recommended to consider radiation. And there's a lot of interest at the moment in making the courses shorter, particularly for those patients who have low-risk disease. And indeed, there are certainly now identifying more and more patients who could maybe avoid having radiation altogether. There's these new interesting techniques where they actually have a radiation probe, and when the surgeon's doing the operation, they put the probe inside the cavity where the cancer's just been removed and hope that that will be all the radiation the patient requires, but also just giving part of the breast radiation afterwards. And again, this is at the moment generally restricted to patients who've got low-risk disease. And finally, looking at the new exciting things coming through. Immunotherapy is the new sexy topic in oncology. So essentially we know for some types of cancer like melanoma and lung cancer, this has now become standard of care. And many patients, when they hear about it in the news, are like, Michelle, why can't I have immunotherapy? This sounds a good treatment. It doesn't knock you around. You don't lose your hair. You don't have chemo side effects. And there's more and more evidence about its role in breast cancer. Currently, it is, as of the 1st of September, available for early stage triple negative breast cancer, so a particular subtype of breast cancer, and that's a really huge development and likely will be also available for women with advanced breast cancer through the PBS. Currently there's an access scheme. But as oncologists, we had to learn a whole new set of skills when we started using immunotherapy, because what this treatment basically does is it revs up your immune system to attack the cancer, which is a great thing, except sometimes it starts attacking other parts of your body. And so we've had to learn about all the side effects of immunotherapy, which are not common, but can be serious. So it's common for it to affect the thyroid gland, and people need to be on thyroxine, perhaps for the rest of their life. But it can also affect the bowel and the liver and the brain and the heart. So it's really something that needs monitoring. And the other very exciting new type of treatment is something called antibody drug conjugates. I'm just going to move to the next slide to explain it a bit. So the longer blue bits are essentially what's called an antibody. And an antibody is, directed at a particular protein. So, for example, for HER2-positive disease, the antibody is trastuzumab or Herceptin that attacks the HER2-positive cancer. And what you can see here is they've glued chemotherapy to the antibody. And what that means is we're trying to minimise delivery of chemotherapy to most of the body and restrict the delivery to the cancer cells. It's beautiful science. And definitely they're going to be the way forward, how we treat many cancers. So we've already got a few drugs, drugs like Kadcyla, which is used for HER2-positive disease. But there's also some others that are currently used in advanced breast cancer that most likely will move into early stage breast cancer. And finally, there's a drug called abemaciclib, which belongs to a group of drugs called the CDK4/6 inhibitors. Again, they're commonly used in advanced breast cancer. They've recently been shown to reduce the risk quite substantially for women with high-risk hormone-positive breast cancer. They haven't yet got PBS listing in this setting, but sometimes there are access schemes that allow patients to get the drug from the company. They do have more side effects, and so we've always got to balance up the potential benefit of it for being on it, because again, these drugs are 2 or 3 years, but I think it's a space to watch because they're probably going to be more commonly used. We've already discussed, KP's already mentioned clinical trials, and clearly they're the way forward in breast cancer to allow us to develop better treatments, better outcomes for our patients, better quality of life. It is an issue for rural patients if you have to travel 2 or 3 hours, and lots of clinical trials are really time-consuming in terms of how many visits a patient has. I think that one good thing that came out of COVID, I mean, I'm from Melbourne, so we had a lot of COVID, so it was introducing telehealth and introducing telehealth into clinical trials, because in the past, clinical trials were like, no, we can't possibly use that modality. But during COVID, they had to sort of think outside the square, and it's a very good model for patients in rural areas to have access to clinical trials if there can be at least some of the visits done via telehealth. I think it's important to let your oncologist or your treating team know if that's something you'd think about doing. Trials are not for everyone. Some patients don't like that loss of autonomy. They don't like someone else telling them which treatment they might get. They want to be involved in that decision making. But if it's enabling you to get access to a brand new, super exciting drug, you know, most patients will take that chance. Bone modifying agents, a drug called zoledronic acid, has been shown to improve outcome for women who are on the hormone blockers, the aromatase inhibitors, and it's now PBS listed in that setting. So that's another treatment that can be added into the hormone blockers and everything else. And again, BCNA played a critical role in getting that PBS listing. And finally, just to think of a couple of other things, genetic testing is really important, particularly for women who have a strong family history or have particular subtypes of breast cancer, such as triple-negative breast cancer. Many tests can be subsidised by the government. I think there have been challenges in Queensland with access to genetic testing. Is it harder to Brisbane? Yeah. But patients can also self-fund it. Again, I hate talking about money all the time, but some women make the decision that's something they'd like to do if they don't meet the criteria for a free test. And that's, it used to be thousands of dollars. It's down to a few $100s, and hopefully over coming years it'll become like just having your full blood count done. No, so most GPs probably wouldn't be comfortable. You do probably need to have genetic counselling, which some oncologists are happy to do. Some would send you to a familial cancer clinic, but if you have said up front, I'm happy to self-fund it, then, the process is a lot simpler. And it's, peace of mind for the patient and obviously for their family as well. Okay, and the last little bit was just about really living well following a diagnosis of early stage breast cancer. It's a common thing for patients to feel that they've been having this intense period where they were, their doctors were seeing them all the time and it was very intense, and suddenly they say, I'll see you in 3 or 6 months. And patients can feel very vulnerable during that time, and I'm sure they're straight on the phone to the breast care nurses to discuss getting back into the world, which isn't easy to do when your body is different and your mind's different. Patients will often say, once my hair grew back, everyone treated me like I was exactly the same, but I was a different person. I had physical changes and mentally I was in a different space. And I think, society needs to get better at dealing with patients once they've got through that early acute period. Yeah, I think you're absolutely right. And interestingly, my patients who did the scalp cooling, who keep their hair, who are going through chemo, say exactly the same. They said, people say because I got my hair, I'm all right, but I'm not all right. And I absolutely agree. I think that, the shock of the diagnosis, the going through the surgery, hormone blockers, radiation, whatever's involved, it has huge impacts. And I think as oncologists, the whole area of wellness after cancer is a huge area that we're trying to really focus on, because, you know, patients who struggle having a baby after their breast cancer diagnosis, and, you know, there was a hurry to start treatment so they didn't have eggs stored, or all those, you know, there's a lot of grieving associated with loss of fertility. If your sex life isn't like it used to be, again, there's grieving associated with that. Some patients do have chronic pain either from neuropathy or from their surgery, and we worry about mental health and bone health after breast cancer. So in summary, it's a common illness that for most patients is curable. We still have to keep working on that 1/3 of patients who currently do unfortunately develop metastatic disease, but we really want to personalise our treatment to that patient and that cancer, and also manage as best we can the long-term complications of treatment. And I think it's really important that the patient feels comfortable with their treating team, that they have trust and honesty with them about how things are going. Thanks. Oh.
I'm not letting you get off that easily. Now, we do have people online, so we have to wait for the microphone to come to you for questions. But I'll kick it off because I know everyone gets, you know, a bit shy. One thing I have noticed and observed through many of the forums is clinicians, because we always have the best that come and present, go, yeah, so everyone has an MDT meeting and blah, blah, and you see patients go, I have no idea what they're talking about. If you're out there today and you have no idea if there was a multidisciplinary team meeting, what can I do to reassure myself that happened, or maybe ask for the information?
Yeah. I think it is important for the patient. I would always report back to my patient, because I love that. I love that I've had a network of people that have agreed, well, hopefully agreed with my assessment about what we should do. But I absolutely think it's true that some patients would just be told, you're going on this and you're doing that. And I think, you know, because that power imbalance, you know, we're not on the same playing field when you're sitting in that patient chair. I think you do absolutely have the right to ask the question about, how was the decision made about this treatment? You know, was I presented at a multidisciplinary meeting? Was there consensus? Because I'll tell the patient, sometimes I'll have a perspective, and I mean, I think I'm lucky. The ones I go to are pretty collegial, but I've heard of other ones where there is a bit of argy-bargy. You know, one doctor wants to do one thing and another wants to do another. But you have to come to a consensus view. And as long as the patient knows there was that discussion and that there were a couple of different paths that could have been taken, but we came down to that point. But I do think maybe we do need to be communicating more when patients are first diagnosed, that you will be discussed in an MDT. Some centres do make patients, I think, sign a consent form, that would be part of the process, and that patients get that feedback about what was discussed about their case. You know, sometimes radiation could or couldn't be given, you know, but when you read the documentation, it might just say for radiation. But, you know, it's good for them to know, well, some of the doctors said maybe you could avoid it. Let's get an opinion and see what they think.
Well, I'm going to ask for a show of hands. Who knows that they would discuss at MDT and that their doctor... Yeah, see? It's quite interesting. It's better than we've had in some areas. Just wait for the microphone, Katie, and then you can...
I can confirm that everyone in Cairns who is diagnosed would have been discussed at an MDT, but I do encourage people, sometimes we get a bit busy in our consults talking about all these wonderful plans, but if you ever do want to talk specifically about what's on the MDT, then we're very happy to go through it. But in Cairns, everyone is diagnosed through IMED, breast screen or Queensland X-ray, and we present all of our cases at diagnosis. So if you have been diagnosed in Cairns, then you have been discussed.
Yeah.
Sorry, so Zoe asked if it was about 15 years ago. I couldn't comment on that because I've obviously only been in the position for 3 years. But it would be worth talking to whoever your breast care nurse was at that point, and we can have a look into that.
Yeah. Or wherever you're having your
Follow up.
follow-up. No, you're done. There's a question online which I'm excited about, which is, I'm wondering if it is safe or part of standard care to have the option to do scans every 6 months to monitor after treatment. I'm smiling because this comes up at every single session.
And do you think we mean breast scans or?
Yeah, I think as someone who's already doing yearly ultrasounds to monitor
Yeah.
benign breast cysts
Yes.
and somehow still ended up stage 2, I don't have peace of mind doing yearly.
Yeah. So I think we do try to be evidence-based in what we do, and really, certainly mammography more than 12 monthly, we would worry about the radiation exposure associated with that, and there's certainly no evidence. And again, with ultrasounds, the general teaching is that an interval of 12 months is quite safe for the vast majority of patients, certainly with a clinical examination at that 6-month point as well. But do I have patients who are uncomfortable with that path? Absolutely. And they do, I think I see all of the discussions with my patients as a negotiation, right? That we want to both be on the same page about how things are going. I think some patients, their anxiety becomes overwhelming and they need to get that psychological support. I'm not saying in this case, but, for some patients who will come in, or they'll ring my rooms, once a month saying, now I've got a sore back, now I've got, my elbow, and they're wanting scans all the time to check out everything's okay. But for those patients where something didn't go smoothly at the start and they've got that concern that they just want to be a bit more vigilant, and I think if we're using a modality like ultrasound where there's no radiation exposure and they're doing it somewhere that does a good ultrasound, I wouldn't have a problem with that. I think some doctors still do practice a bit more paternalistic medicine, and some of them will say, nope, that's the rules, that's what the guidelines say. And look, to each their own, but that's just not my style.
So just continuing on the follow-up, so say your side effects are continuing.
Yes.
So treatment's finished, you're going back just for your annual scans. At what point should I be connecting with you or the breast care nurse, or, what should I do if it's actually unmanageable? Because I think what does happen is everyone thinks, and sometimes I've heard, that a clinician will say, well, you're alive, so be grateful. But when should we actually go, I need more help with managing the side effects?
Yeah, I think that's a very, very personal question. I think patients sometimes say to me, when do I need treatment for hot flushes? Like, is there a number? And I say that there is no number. Like, some patients will have 2 a day, but they're so distressing, they're associated with so much anxiety and feeling unwell that they want treatment. And another woman might have 50 a day and she goes, yeah, not worried about them at all. So I think it's a very subjective thing. I always say to my patients, I'll see you in 3 months, but I would absolutely expect you to give us a call here if you felt how things were going is not sustainable. Now, I then do rue that when I click on at the end of the day and there's a lot of phone calls to make, but I would much rather that than they come in 2 months later and they're falling apart. Or, worse still, and we've all seen it, they've stopped their tablets. When I moved from one practice to another practice, we were sending out letters to all our patients, and I and my colleague, we run the business together, we were quite shocked how many patients we saw once or twice and we never saw again. And most of them it was to start hormone blockers, and I'm pretty sure most of them got some side effects and made the decision that they weren't going to come back. And we were really disheartened that the number was so high, because we would hope that we're approachable enough that they could ring and say, Michelle, plan B, this ain't working for me.
Now, Barb, can you remember your question that you had when we had our connection today? I can. I think it's your fingers, side effects, your fingers, your neuropathy.
Yeah, they just, what was that?
You can do it.
Yeah, the middle fingers, they get caught like that and they get in the road, and I find it hard to undo doorknobs or bottle tops or whatever.
Yeah, so I think you've got a trigger finger, which is a really common side effect of don't want you to tell me your treatment, but or the aromatase inhibitors, the anastrozole or letrozole or aromacin, they're the tablets can cause this as a really big problem. I'm going to be very rich if I come up with something that can help these symptoms. I mean, I think if they're becoming really disabling, there is some literature about swapping from one to another, that about a third of patients are better with one of the drugs versus another. There was a lovely study that looked at acupuncture associated with these joint symptoms and did actually show a benefit. But again, it's hard tracking down someone who's good at acupuncture. And then using, yoga and stretching, all those techniques to try and help as much as possible. And the other thing some people do get benefit from, but I'm not sure about, is curcumin or high-dose turmeric. Some patients find that to be beneficial for their general stiffness of their joints. But you've picked a good part of the world to live in so that you don't have a Melbourne winter.
If you're looking for really good acupuncturists, there's a really good one in Cairns. Sorry, I don't know their name. They're on Shield Street. But in Innisfail, there's a lady named Agnes Kim. She does Chinese medicine plus acupuncture, and she is absolutely brilliant.
And we do want to remind everyone that whatever you're having, check in with your oncologist, so that, because there are certainly, and Tonya will talk about this in a bit more detail, but there are some medications you can take that may interfere with your endocrine therapy. So any other questions? Just wait for the mic, sorry. I know, I'm that person. Make sure if you're online you keep asking questions because I can see them.
Does everyone get an oncologist? Because I never saw an oncologist. My surgeon basically has dealt with all of it. And if you don't feel like you're getting what you need from your doctor or oncologist, how easy is it to change to a new one?
Yeah, good question. So, no, I don't think all surgeons refer all patients, particularly if they're going to put them on, if it's clear cut that they're going to have, the operation and a hormone blocker. I think most surgeons would refer patients on, but not everyone. I think that you would be, well within your rights to talk to your surgeon about if you're having side effects of your treatment. I'm wondering if a medical oncologist would be someone good for me to see. Second opinions are a really common thing in oncology. I mean, we're dealing with patients are dealing with their lives, and they are absolutely within their rights to, if they don't feel the relationship's going like they wanted it to. Often word of mouth is a good way to hear about other people. And then you'd see your GP and get your GP to refer you on to someone different if that's what you wanted to do.
So my experience tells me particularly people in regional areas are less likely to want to go for a second opinion for that fear of the doctor might see me in a different way. And I am actually supporting a friend right now in a regional area in Victoria whose mother needs a second opinion because I don't think she's getting all the options. And the mum is completely so scared that if she wants to return back to that clinician that they're going to see her in a different light. So I do think how getting a family member to perhaps be the person, like if you don't feel comfortable to do it, to actually be the person that says, I am asking my mum to get the second opinion, because if it was your mum, you would want the same. And so I think that there are some practical tools we need to give people, but the good clinicians know and understand that it is your life and you need to go and find the second opinion. And I think the more we can actually empower people to get that second opinion, it's really important. And to just have that reassuring conversation, if that's all it is, then God, isn't that worth it, from the mental load that you're clearly carrying as well. So I think, that reassurance and just saying to the clinicians, it's not about you, it's just me being reassured so that I can feel better about what's happening to me longer term. So I really encourage people to get second opinions, but I get that it's really hard. It's really hard. Any other questions? Yeah, just wait for the good work, Nicole. Good student.
After my mastectomy, I was told that I couldn't have my blood pressure or IV taken on the left side. And recently I had day surgery and they said that that's a myth.
Yes, so the whole question about, so in the olden days, when patients had a lot of lymph nodes removed from under their arm, the worry was we could precipitate lymphedema by traumatising the arm, either with, a drip or blood pressure or anything. And really, over recent years, we're seeing much less lymphedema because they're only taking out fewer lymph nodes. But B, it hasn't really translated that there is this issue to the degree that it was thought to be. And these days, most patients, we believe, unless you had a lot of lymph nodes taken out or you've had pregs. Oh, I mean, if you had, 10 or 15 or 20 lymph nodes removed, or if you've had lymphedema before, then certainly that arm should be left alone. But I think for most women these days who have a sentinel lymph node biopsy, we think the risk is so tiny. And every patient will always say, the only arm with the good vein is on the side where I had the surgery. And so they're digging around in here, but I can just see this beauty here. So I think things are much more relaxed about it these days.
Any other questions? Well, please thank Michelle. That was, as always, I always learn something different from Michelle. And it's like, honestly, it is such a privilege to work with you. And we're so grateful for all of the volunteer time you give to BCNA to make sure that patients are seen in a different way. But I also know that you're extremely amazing at advocating to the other health professionals to step up and be better. So thank you very much.